thank you very much for the invitation to be here. I'm going to talk about COVID being airborne and amongst our mistakes, and I kind of deliberately left the title a bit vague. I'm going to have a declaration, and that's largely that I've had a view from the sidelines and from published literature, and that's not the same as being in the thick of it, and I acknowledge the limitations of that. Now, most people think of a mess as something that happens on a carpet, but a situation that is confused and full of problems is also termed a mess. And I think that's kind of where we are at the minute. We do have problems and we are confused. So let's take a look at some of them. I think whilst waiting for what has been called perfect proof, we omitted and are still omitting the precautionary principle. And as a consequence, there has been unnecessary exposure and severity of illness and deaths. And the current one is that it doesn't cause hepatitis in children. We shouldn't really be waiting for this perfect proof. I was in Fife the other day, and this restaurant was informing me that the best way that I could prevent any transmission of coronavirus inside was to do hand hygiene before I entered. And quite clearly, that's nonsense in terms of the overall risk. And some people now are suggesting that we tone down on testing, that it's not going to be a problem if we do so. This is a bit of system dynamics. I'm not going to go through it, but because I can't even work out how you press the button. Nope. Anyway, so the one at the top is testing on admission's got a negative red box, and all the red boxes all the way down are what will happen if we abandon our testing. We won't get safe patient placement, we'll get outbreaks, and we'll get bigger outbreaks. This, people are giving themselves a pat on the back with. I don't think it is worthy of a pat on the back. Nosocomial transmission of COVID, less than 1% of all cases. We shouldn't be measuring nosocomial COVID, i.e. COVID that's acquired in hospital, against all the cases that happen in the community. We should be measuring it against the cases that are in hospital. And when we do that, from this graph, so the dark blue lines are the ones, now they're calling it definite hospital onset, but this is 15 days post admission. This is hospital acquired. And the dark blue lines, if you look closely, they're actually going up, and it's about 4 in 10 people in hospital with COVID are getting it in hospital. We're still ignoring very important evidence about what masks work best and what impact that can have on staff safety. According to the Financial Times, about 90% of people have had it, and your man, Sajid Javid, is okay with that. We've done okay because more people died in Germany. I'm not considering that a success. And about a plane full of people, or the passenger content of a plane full of people drops out the sky every couple of days. I find that unacceptable, but apparently it's okay because we're living with it, we're dying with it rather. And the public are fed up, absolutely fed up of the government behaviour, of mitigations in general. And if we want to go further, then we have to get somehow them back on our side. And a lot of people are talking about, oh, I had COVID and I've got a bit of brain fog. And I think brain fog's the wrong term because fog lifts. This might not lift. In this paper here, it's referring to, talks about aging 20 years in some people post-COVID. It's the brain, it's the virus having your brain for breakfast. And when we talk about it like that, it's something we really don't want. So it is a mess, and we do need to clear it up. And there's more toilet roll on this than we had intended. So we need to press the reset button, and it's important when we're dealing with outbreaks, we're dealing with imperfect evidence, and we will never get it right all of the time at the beginning. And the error is never in getting it wrong when the evidence is absent. The error is failing to put it right when the evidence is present. So one great tool is situational awareness. It was devised by Mika Ensley. She wanted to understand what were the pilots thinking, what was their understanding before they pressed the button that crashed the plane. So 3 questions: what's happening, so what, and what will happen next if nothing changes? And if you have an accurate situational awareness, you have the best decision making. So let me give you an example. People are being transferred to care homes without testing. They may be infectious and cause transmission in the home. They may well be outbreaks and mortality associated. And if we have that understanding, then we should be doing something about making it safe with testing pre-transfer and with isolation until we know that they are no longer infectious. Now that's an accurate situation awareness when we think about the pilot having it, but what we really need in this situation is team situation awareness. We all need to be on the same page, and I'm going to show you some mental models for that. I'm going to introduce you to a book, if you don't know it, called Good Strategy, Bad Strategy by Richard Rummout. And he said that all man-made disasters, and I don't think we made the virus, but I think we made the disaster that came with it. All man-made disasters have these 5 intertwined elements of human decision-making. And the most important one is engineering overreach. And engineering overreach happens when the ways in which a system can fail and the consequences of these failures are greater than a system's ability to comprehend and defend against them. So did we have engineering overreach? Were we all sitting there in October 2019 thinking there will be a pandemic and it will be spread by the airborne route? It will spread rapidly planet-wide via travel initially and then on in indoor spaces. We won't be able to tell who's infectious. Millions will get it. Hundreds of thousands will die. There will be long-term sequelae. There will be no vaccine initially. The NHS could possibly fail. And the NHS staff could be infected on a massive scale. Was that our understanding as we, sat there towards the end of the year? If it had have been, we would have mandated indoor air quality for the past 30 years, especially in transport. We would have made the NHS safe for people. Indoor air quality would have been mandatory. We would have understood where are we worst and where are we best. We would have had reusable green stockpile of respiratory protection equipment, etc., etc. And we would have tried to have done that on a worldwide basis. So did we have this? No. So we collectively had engineering overreach. There was a preparedness tent, but the engineers were not inside it. Let me introduce you to Mount Vesuvius in the Bay of Naples. There is a hospital halfway up. And I said to the guide, why did you build a hospital halfway up a live volcano? And he said, we forget it's a volcano. And it's kind of just like we forgot or we didn't believe enough that this would happen in our lifetime. We had engineering overreach. We built a hospital halfway up Mount Vesuvius and it blew its top. This is an erroneous assumption of safety. And that's a term I want you to use when you're making decisions about people. Is this an erroneous assumption of safety? And that's a phrase that could have been used so many times over. I have no time to go into high reliability theory other than say that the 5th one, deference to experts and expertise, I think, failed on miserably. And I don't think for a lot of the time the infection control people were the experts that should have been making decisions. This was the pre-pandemic erroneous model of droplet and airborne transmission. We have an infected individual and he either produces droplets which contain pathogen, which will splash on a face, our mucous membranes, or he will produce pathogen inside airborne aerosols, which we will inhale in. Now, can we really have expected some pathogens to hang on a minute, get in the small ones, we're just for the small ones, so they all jumped in the small ones and it was inhalation? Or are they all sitting there going, no, actually, we'll just jump into the large particles? This has been described as defying physics. Now, if we got the mode of transmission wrong, this is what happens. We get the precautions wrong. So at the top, we have airborne transmission, we would wear respiratory protection. If we had droplet transmission, we would wear protection against splash. So we get the mode of transmission wrong, we get the precautions wrong. And here's another erroneous assumption of safety. This was the first guidance, the predominant modes of transmission are assumed to be droplet and contact. We didn't know. And we failed to imply the precautionary principle, and we didn't protect everybody. So we got the mode of transmission wrong, got the precautions wrong, and we failed to defer to experts. And I would say, what are you doing here? What are you doing here learning about indoor air quality when we don't have one infection control guidance that says it's airborne? We'll come back to that. Okay, so we did have guidance, 2013 guidance, which categorised the size of particles. And it said coughs and sneezes are what usually causes your droplets. They impact on mucous membranes. Droplets contain high numbers of pathogens, and most respiratory pathogens are spread via droplets. Conversely, the aerosol scientists were saying most respiratory particles are less than 5. Most of the pathogens are in the particles which are less than 5. And most respiratory diseases are, in fact, airborne. There's a complete dichotomy of opinion. Now, if you further spread out what we now know, so the big droplets are splashes, they will fall to the ground or fall on you. The aerosols we will inhale in. But then you've got this category here, which remain airborne for many minutes according to the guidance. They're greater than 5 and less than 20, but they evaporate rapidly. So what precautions are we using for those? Do we put the droplet protection on first and whip it off and then put the airborne on? This category was never even considered. And it just further shows the flaws in our thinking of pre-pandemic. And we can blame the CDC. We all followed the CDC. Yeah, that sounds about right. We'll all follow them. And in all honesty, we didn't, until the pandemic, have much in the way of disasters. And then we had the procedures which generate aerosols. I'm going to park the dental procedures which generate aerosols. And there's a beautiful illustration here by Kimberly Prazer, who talks about, or who's illustrated what precautions we're using for procedures that generate aerosols and ones that don't. And you can see here for droplet precautions, talking, exercising, shouting, and coughing all produce vast numbers of aerosols. And on the other side over here, we are using higher level precautions for procedures which don't generate aerosols, and that doesn't make sense. And what Klompers and others have said is, okay, there are risk factors that associate sorry, can you stop? Because I can't think. So there are risk factors which mean that aerosol generating procedures are associated with infection, and they include closeness to patients. They include the number of healthcare workers in attendance and the duration of the procedure. Now, that also applies to people caring for people with COVID, and why we weren't giving and aren't giving respiratory protection for these, I don't know. Excellent paper by Greenhow and others suggesting 10 reasons why this is airborne. I'm going to very briefly go through them. Super spreading events can only be explained by airborne transmission. We've got documented evidence of it going under doors. We've got asymptomatic transmission. Excuse me, it's more indoors than outdoors. We've got nosocomial transmission when we're well applying droplet and contact. It's been found in the air in the absence of AGPs. It's been found in ducts. It's spread around, or spread between caged animals around corners. We don't have another hypothesis, limited evidence for droplet, and the one that wasn't from Greenhow but an outbreak, it spread backwards 5 meters on a bus. This is an airborne infection. So let's have some mental models that represent our situation awareness, if you will. This is perhaps what we thought of as transmission risk in a home, but it's more like this. This is what we maybe thought a corridor should look like, a bit of hand gel everywhere. But in actual fact, if that's the risk, then the hand gel's not going to do so much good. This is maybe what we thought of as school, and look what we have in school, and we urgently need good air quality in schools. And this is maybe a hospital, but also within a ward there can be eddies. If you've got lots of people moving about and doing stuff, doors opening, doors closing, we will get eddies. It won't go as designed. Important paper by Lindsay Marr. Now what she's talking about here is the top, I can't think of your one, top left over there, that's the picture without any precautions. The large droplets are falling to the floor. The conversational space is where the aerosols are most dense. And if you look at ventilation, disinfection, filtration, they all reduce the amount of particles in the space, but they don't change the risk in conversational space. So that's a very important point to make. We needed guidance, and we haven't had good guidance. This is a literature review ongoing literature review. It's up to version 25 now, and it still says transmission is mainly through close contact mediated by respiratory particles. That says it's leaving me as infectious, it's infected somebody else close to me, but it's not telling me, is it going by airborne? Is it going by droplets? Are we eating it? Are we touching? That's not good enough for version 26. This one here has left out a mode of transmission altogether. And over here we've got notable learned societies, of which I'm a member of one of them. And they said it's probably droplet, possibly airborne, but they failed to define either. So I think they also failed on the precautionary principle. I'm going to look at one of their citations because although they used many, many citations, the bit they used where they decided, is this probably droplet, they only used 4 references. 30, 51, 59, and 82. I'll let you into a secret. 51 and 59 are the same outbreak. So let's have a look at 82. Here's reference 82. Lack of COVID transmission on an international flight. And the author of this letter, not a paper, says, however, the lack of secondary cases supports droplet transmission. How can that be? How can it support any mode of transmission when no transmission happened? This was not a paper, it was a letter, so it wasn't peer-reviewed. It involved no transmission and provided no citation to support its claim, yet it found its way into that document. I don't explain. The same 4 references that were used to determine that droplets were probable were the same 4 references that were used to determine if airborne was possible. And that's just nonsense. So if you believe transmission close to a source is droplets, you'll see droplets. You'll report droplets. You'll publish droplets. But droplet-only respiratory transmission doesn't happen. It cannot be evidenced. Now, if we don't know, we shouldn't boldly declare. And WHO boldly declared, and they were wrong to do so. This was their scientific brief on White's droplets. They used 16 references. I went through every single one. Only 5 mentioned a mode of transmission. And basically, they didn't present any evidence to support droplet transmission. Now, where are we now? Are we winging it? Are we optimism? Are we surrender? None of these are effective strategies. So what can we do now? And does it matter anymore? It depends if you want the virus to have your brain for breakfast. I think we need to recognise it is airborne in guidance. Why else would we have all these people here? This is a great paper presented by Sharon Bamber, or poster at ECMID. And they've done CO2 monitoring of every single clinical area in their place. They know where their risks are and where they are through the day and night. We should have been a year and a half into this. Nice little gallery here who is following the independent SAGE. They're putting their scores on the doors. They're going to have their CO2 levels being monitored. They're doing exactly what's asked for. Belgium is going to have every public place to monitor its CO2 and what their airborne requirements are. So before you book indoors, and let me tell you, conference-related outbreaks are a thing. We've got about 200 people here in the room. There's about 4 people infectious with COVID. But before you book an event, say, what's your air quality like? Because we're never going to get air quality if we don't demand it. The government's gone on holiday. They've moved on. We have to do it from the ground up. How do you ensure your indoor air quality? When Paul asked me to do this talk, that was the first question I asked him. What's the ventilation? And we want that for hospitals, obviously. So given this is our mental model, here's my situation awareness for hospitals now. I think we are in between COVID waves. I think hospitals are still COVID accumulation centres. We admit patients with it, which fail to apply airborne precautions. There continues to be unacceptable levels of nosocomial transmission. People are being infected, reinfected, debilitated, and some will die because of a lack of airborne precautions. And unless and until we apply airborne precautions, this will continue. I think our decision-making should be aiming for zero COVID, assessing all clinical settings for airflows and CO2, using RPE to reduce close transmission, and apply air cleaning to reduce far-field transmission. You might be waiting for the perfect proof. I am going for the precautionary principle, and I thank you for your attention.